Thanks everyone for joining us. I think a few more people are gonna trickle in, but we'll get started for today. This is our weekly Center for Healthcare Policy and Research seminar series. So some of you are coming from your existing graduate seminar, or for continuing medical education credit, or just really interested in the topics that we go over. So we welcome everybody to the seminar series. We're crazily almost wrapping up our winter quarter here. We're getting close, a couple more weeks in the winter quarter. And today we are really, really fortunate to have an expert from here at UC Davis coming to speak with us today, Dr. Shelly Fritz. She is an associate professor here in our Betty and Irene Moore School of Nursing and is a real expert both on nursing science. So she's a nurse researcher and a nurse investigator, but also in the health technology and I would say cutting edge health technology space. Um, She's been with us at Davis for a relatively short amount of time, maybe a little over a year or something like that. But comes with a long-standing history of a lot of interventions in community-based settings and with community partners. And so I think today she's going to talk to us about sort of a broader portfolio of smart technologies to support aging in place. So thank you so much for joining us, Shelly, and please take it away. She says she loves questions and we'll have them in the chat and we're going to have plenty of time at the end to go in deep. So take it away.
Well, thank you, Courtney. It's wonderful to be with you all today to talk about design and implementation of smart technologies for aging in place. So just to give you a little bit of history or background about my nursing practice, I became a nurse in the late 80s, early 1990s. And my background has kind of been like 5-year plus buckets in each of these areas. So public health and home health, emergency nursing, hospital leadership and governance, where as a publicly elected hospital commissioner in the state of Washington for 5 years, and chaired a hospital board teaching nursing at the pre-licensure and graduate level, and then finally getting my PhD and becoming a nurse scientist. All of these areas really inform my work. And I would say the areas that most inform my work were my time in the emergency room and in hospital leadership and governance. So I want to take a moment to acknowledge that these entities have supported my research over the years and have made it possible to discover some of the things that I'll share with you today. I have no conflicts of interest to declare with anything in this presentation. So the problem that I sort of left the hospital system to go into nursing research and address is the growing aging population, where we have right now the largest number of older adults per capita in the US. And of those age 65 and older, approximately 90%, 95% actually, are managing at least one chronic condition. And I saw this working in the emergency room all the time. So, of these folks, they are part of a fragmented healthcare system, which sometimes results in them not being able to reach their goals, which primarily is aging in place and remaining at home as long as possible. So, innovative solutions are needed to immediately change what we're doing with older adults because of the pace of the growing number of older adults, because of once you reach a certain age, the level of functional and cognitive decline increases. And how we help that is that we catch health events upstream before the emergency room. And how we do that is through changing how we think about how we deliver care and how we monitor health. I'm personally invested and involved in this space with aging parents. And also, like I said, with many stories that I could tell you of older adults who came into the emergency room and likely, in fact, in some cases I knew never made it back home. So this is for those folks, and it's about that space. I'd like to start by talking a little bit about and reminding us that designing for older adults requires intention. It's different than when we design for the general population. We know that older adults' sensory perception systems change, and we have to think about that when we design technologies for them. They need intention around physical accessibility to devices, They need to be able to engage at a cognitive level that matches what their cognitive level and diagnosis are. And they have emotional, social, and ethical user experiences that we have to be intentional about, given all of the things that I also just mentioned. In addition, thinking about how they use a system or how they practically and pragmatically integrate a technology for health monitoring or improving their health in their home is really important, helping them be able to navigate that. So after coming to UC Davis, to build on these ideas and to try to work with others to innovate and create solutions for older adults, I started the SAGE Lab, which stands for Smart Aging and Gerontology Environments. I love the name because sages are the folks on the earth who are the older adults. And so this particular lab focuses on three main areas. One is designing and testing a smart home that uses these kinds of devices, sensors, wearables, robots, for a future health monitoring smart home for older adults. Then we also focus on the user interface, how people interact with the technologies that we develop, and that's older adults themselves, that's caregivers and family, and that's also the clinical team. And so all of that rolls into this idea of adoption. How do we use something, and how will it be used by someone in the future? And with that, we are looking at training nurses to be able to work both in academia and in industry, in the health technology industry, at very high levels, design teams. Industry has been pretty good at inviting docs to sit on their design tables. By docs, I mean physicians. The ones that I consult with, I encourage them to think about every time they hire a physician to think about hiring a nurse because we do different things and we bring different skill sets to the table. And nurses really sort of own the domain of the human response to illness and how we can do the integration at the bedside. And in this case, that means in the home. So sort of the trajectory for training nurses in the lab is, they help come up with ideas based on their years of clinical practice, design a product or test something that's off the shelf, think about how that could be integrated in academia or industry, meaning a product that people could use, or if their goal is to become a scientist, how that could be better improved through academia and research, and with an intentional focus on application and translation. So now they have a little bit of background on who I am and what I'm doing here. Let's talk about a few of the studies that are really exemplars of how we design and implement smart technologies for older adults. The main thing that I work on right now is an NIH-funded study through the National Institutes of Nursing Research, which we call a Clinician in the Loop Smart Home. And this is a renewed R01. So we actually started this work in 2016 with the first R01. And what we're doing is designing a unobtrusive, continuously monitoring health smart home for older adults so that they don't have to interact with the home, but it will help monitor them with their health. And this comes from the idea of just one too many older adults coming into my emergency room with the life alert still around their neck and the button never pushed for good reasons. In some cases, they were unconscious or their blood sugar in one case was too low and the gentleman didn't remember that he had it on him. And so came into my emergency room by ambulance and I cared for him. And this particular gentleman that I'm telling you about ended up in the intensive care unit. And if he made it back home, it would have been a long time given the secondary issues based on what he experienced. I think we can do better than that. So this idea is really about moving triage upstream from the front desk of the emergency room into the home and not asking the older adult to have to do anything to interact with the system. And so we put sensors throughout the home, like you see on the floor plan here, for whole home coverage. And these are the types of sensors that we use, mostly passive infrared sensing, where we track movement around the home. We put 3 to 4 sensors per room. And so when someone moves from the bedroom to the recliner chair in the middle of the night, or they go to the bathroom and they don't come out for 3 hours, these are the kinds of things that we can automatically recognize. And we think through this process, we can automate recognition of health changes because when people don't feel well, they move differently. And that does not require a human with eyes on an older adult to be able to recognize that. In this particular study, we chose not to use any cameras or microphones, even though there are teams across the nation that are doing similar work, but using these. And that's simply because I grew up rural and those folks really value their privacy. And when my dad told me, hell no, sis, you're not monitoring me like that, I thought, well, let's see what we can do with this. So this particular study doesn't use cameras or microphones, but we do actually deploy Apple Watches to our research participants to help with the training of our algorithms, knowing who's who in the home so that we can do multi-resident homes without eventually having to have somebody have a wearable. And in this study, they do voice memos to us once a day to let us know how their health was, and we do use that information, but it's turned on by them and automatically turns off. So that's a little bit about what we're doing with the sort of the smart home and setting it up. So now let's talk about some of the common activities that we look at that turn the data that you see down here, which is just a date and a timestamp, the name of the sensor, which we name it according to where we put it in the home, and whether the sensor is on or off, whether it's sensing motion or not. These are shown here are some of the common activities that we look at both inside and outside of the home if the person is wearing a wearable like an Apple Watch. And these activities give us a human behaviorome or a holistic, individualized picture of an older adult and their behaviors and the relationship to health. So with this information, we can use machine learning to map these activities onto a variety of clinical values or standardized scores that can assess things like cognitive health, memory performance, mood, physical health, and more. Some of the things that we look at related to this are activity durations. And for this, we're talking about the time spent each day on predefined activities and also discovered activities. We look at activity occurrence times, and this means that we look at the time of day that an activity occurs, and we calculate that by the hours and minutes past midnight of the first and the last occurrence each predefined and discovered activity. For mobility, we look at the amount of movement both inside and outside the home, and we look at things like walking speed and number of steps and many more other items. We also reverse geocode location types that are visited outside of the home. For sleep, we look at daytime and nighttime sleep duration and location. As a former home health nurse, location of sleep is something that was always important for me to know about with my patients. We also look at things like the number of sleep interruptions and sleep efficiency and like 8 different other sleep measurements. We look at daily routines, and for this, we look at the complexity or the entropy of the daily routines and the number of daily events and activities, the minimums and maximum inactivity times, things like daily variance in activity durations, occurrence times, and locations. And we also create a periodogram-derived circadian and diurnal rhythm for our participants. So using the data, again, like you see here, which is really, low fidelity data, which is very privacy enhancing, to be honest with you. We use these sensors and the data to extract features like frequencies and means and maximums and trajectories. And we then apply machine learning tools like hidden Markov models and support vector machines to identify a behavior like a bed to toilet transition. And those transitions can be important to nurses to know about, depending on how many are happening. whether or not there's a change in the frequency and duration of that, for example. But this is how we can derive an activity that can be associated with potentially with a health event around this. And I'll pause really quick and just say that some of these technical slides are actually created by my engineering partner, Dr. Diane Cook at Washington State University, which is where I came from before I came to UC Davis. She continues to be a really strong engineering partner with me in this work. Certainly, this is interdisciplinary work that can't happen in a siloed way. So here's an example of a behavior change that we detected in someone who was diagnosed with lung cancer. This is an 86-year-old female, and you can see like there's a breach in activity at week 10 here. And these are in essence 6 different machine learning techniques or lenses, you might say, with which we look at the same data. And so it's interesting that in all of these, week 10, this is when she started radiation therapy, we saw a significant change in all of the different ways that we looked at this. And the machine learning model told us that 2 things that it really relied on to discover this information were changes in the participant's sleep pattern and the amount of time they entered the home from being outside the home. So now let's look at another example of what we can do with this kind of activity monitoring. Here I'm showing 3 different activities of an 89-year-old male over several weeks. And if you look at the activity level up here, you can see there is a significant change in overall activity level. So let's take a look at what's going on there. This is a 4-day span where actually on day 1, the older gentleman fell and ended up in the emergency room, but thank God nothing major happened. There was some major bruising and he was quite sore. And so you could see he really laid low for 3 days afterwards. So this is a way that we can automatically recognize a health event that has happened. But what we are also interested in on our team, and really it's the holy grail that we seek, which is keeping people out of the emergency room if possible. And that is what's going on with people's behavior in this time frame just before a major health event happens. And so, as a part of this renewed RO1, one of the aims is that we're looking at whether or not we can predict 1 to 3 days in advance that a health event or a major health event may happen. We're only just beginning our 2nd year on this, so we're not there yet. So I anticipate there might be questions at the end about, well, what are we doing and how are we doing this? And what I will tell you is we're still early in the process. I just moved here, got everybody enrolled in the study, and we're starting to work on it now. So I'll be able to tell you maybe in another year or 2 where we are on this, or hopefully we can do it faster. Anyways, this is about predicting a health event. So with all of the cool things that we can do, again, with this very simple data, it basically is meaningless if we can't communicate about this evidence and about this data with the right people. So that's the docs, the nurses, the patients, and the family. So as I mentioned, what we're doing in our lab is we're also working on how do we provide information that's meaningful to the right person at the right time. And so some of the things that we do with the user interface are come up with different ways to represent the data to show what's happening with our participants. And this is just a simple example of one of the tools that we came up with. And this shows, like how much activity or how active is somebody during the day, how much sleep are they getting, how much time are they spending outside the home, where are they in the different areas of the home in a 24-hour period, or you could do a 30-day period. I love these because I think of people's activity in the form of RPMs. If you've heard me say this talk before, you know that I am a Formula One fan. And so many of my data representations involve these kinds of scenarios because I think it's just a great way to represent someone's activity level. So here's another design of what we call a data dashboard. And this was designed for a clinical team versus older adults or their family. And we did this a few years ago and submitted it to JBHI, which is a Journal of Behavioral Health Informatics, and actually won an award for the article for this particular design. And in it, we drew from my emergency room nursing days and the triage coloring that we used, and we assigned the coloring across the different activities with some summary information that we were envisioning potentially case managers or home health nurses would be able to use to help manage their patient load with the automated information that would be coming from the smart home. So by combining all of these inputs from both sides that you see here, we can train our model to identify clinically relevant behavior markers, which make up in a holistic way this behaviorome that I mentioned before. And some of the examples of behaviors that we have associated with, not correlated with, but we have associated with different diagnoses or chronic conditions are a change in bathroom use. I mentioned that that's a pretty easy one to associate with urinary tract infections. And for that, we look at the frequency and duration of time in the bathroom. And that's super important for older women who oftentimes don't feel the symptoms as they're manifested in their body. And so sometimes the first symptom they feel is this dizziness or vertigo that causes them to fall. And then they end up in the emergency room with broken femurs, broken hips. And these secondary things become what in some cases cause them never to be able to go back home, which is the opposite of what their goal is to remain at home as long as possible. And so another thing that we look at is decrease in kitchen or refrigerator use. And we have had one person, for example, a 92-year-old who was diabetic and did not go to their kitchen or their refrigerator. And by 1 o'clock in the afternoon, this was an anomaly. So a member of the team called the person, and it turns out that their best friend had died the night before from high school. These two women had lived a very long time, lived near each other, and she had not gone to the refrigerator or gone to the kitchen at all. She hadn't actually eaten anything, and she was a pretty brittle diabetic. And so this was an important finding and something that could absolutely be automated in real time for older adults trying to remain healthy at home. Another thing we look at is sleep location. Changes in congestive heart failure, changes in COPD can cause someone to go from sleeping in their bed at night to the recliner chair where they can breathe better. Pain, we've shown that pain changes people's sleep location or sleep patterns at night as well. More time in the recliner chair is something that people do when they're not feeling well, and the change in the amount of time they spend outside the home. So let's shift again from the clinician in the loop, which really focused on sort of a connection between a participant or a patient and their clinical team, to how do we envision something that could work within a community approach to care so that we can see whether or not, A, we can do this in a cost-effective way, because we do have to think about when we generate information and we provide information, who's going to do something with it, right? And what we know from, and what I know from being in healthcare forever is like, don't give me information or alert that I have to act on if I can't act on it. You will hear that, unfortunately, in healthcare a lot. But that is a reality of one of the things that we're dealing with. And so I had this idea of can we pull in some of the tenets and aspects of public health nursing that make it so effective and use the smart home in that way. And with funding from the Betty Irene Moore Fellowship for Nurse Leaders and Innovators, which is how I found UC Davis and ended up here ultimately. This project, this 3-year project, I designed a community in the loop smart home where we created a system that could escalate alerts from the participant themselves to a friend or family member, and for those who didn't have a friend or family member, to a community health worker. We enrolled people who were age 50 or older because our community partners asked us to reduce the age because their constituents, because of many of the difficulties and tough lives that they had, suffer chronic conditions younger and die at younger ages. So we started with enrolling people age 50 plus. We hired community health workers who were bilingual and bicultural in 8 different communities. We had 8 different languages represented in this study, and we built and deployed a $400 smart home with just one sensor per room. And so here is a dashboard or a user interface that we created for the community health workers and the older adults. Although we found that our older adults who were managing a chronic condition and experiencing poverty, and we knew this because we partnered with subsidized housing and the housing authority in our local community in Southwest Washington is where this study was done. These folks did not actually engage with any of their data. Very, very small percentage of them engaged with any of their data. But the community health workers, we wanted them to be able to get on a dashboard and look at information about their participants. And so, because they're not going to want to look at bar graphs and line graphs, we created this that would update with words for them. So let's just say this is Rick, and it says for activity for Rick, he's spending most of his time in bed today. And it turns out the same thing for the last week. And then he's also trending towards less eating. And so you can see that this is somebody who's possibly not feeling well. And to make a long story short, indeed, he was not feeling well. And we knew that because the community health worker called them based on the information that she had. But this is what the nursing team looks at, or the research team looks at for the data that we generated from this study. And this black bar that you see circled in red was multiple days where the person didn't leave their home. And you can see prior to that, they did have a pattern of leaving their home every day. And this person actually went for a walk every morning. This resulted in a home body alert, we called it, and the community health worker took action, supported the older adult in getting seen by their doctor. And we believe, this person had a better outcome because of that. In fact, they told us that. So the results from this study show that we are capable of saving cost and saving lives. But the reality is that we have a lot of work to do in order to make this a scalable, viable solution. One thing that we do know from this study and others is that we have to offer the human connection alongside the technology. So let's switch again to what we're calling the Sage chatbot. We developed those data dashboards before large language models became so prevalent and sophisticated in the last 12 to 15 months. And so with the emergence of large language models, it has really changed everything about how we think about, as a nursing science team and the engineers that I work with, presenting information to patients, family, and the clinical team. And so in the current study, we are starting to institute a new chatbot that our nursing team, who makes weekly phone calls, telehealth calls to our participants to collect data, but ultimately that's representative of what a home health nurse would do with their patient panel. The chatbot is being designed to take in information. It's a large language model that's privacy enabled, and we're wrapping around the large language model de-identified data from our participants that includes the smart home data, like you saw, just the date, the timestamp, the name of the sensor on or off, etc. The wearable or smartwatch data, along with the voice memos of participants that have been run through a whisper, which removes all proper nouns and then transcribes from voice to text, and that gets put as an input into our model. So all of these wrappers are on the model, and then the output looks something like this, or this is the goal. This is an example of what an output would look like. I will tell you that right now our outputs don't look this good, but we're going to get there. This is the goal of what we want to do with the privacy-enabled chatbot, and that is a nurse would be able to hop on and say, "Can you provide me an update on, whatever their patient is?" And that information from the patient would be up here. For example, in this case, the patient, let's just say, has congestive heart failure, class 3, and that they were admitted into the home care program, on this date. They've been in the program for X number of weeks, and that their home situation is something like their daughter lives nearby and checks in a couple days a week. And then this person may or may not have opted into spiritual care. And so the nurse says to the chatbot, "Can you give me an update on this patient?" And the patient would return the good old fashioned SOAP note. And so that would be the assessment from the previous week, although you could set that to be whatever date range you would want. And the subjective statement would be, for example, per the voice memo, "I am not sleeping well and I am pretty discouraged and ready to throw in the towel." So that would be a good old-fashioned subjective note that we might have written in a chart long ago before there were electronic health records. And then the objective assessment would come from the sensors because they are directly and objectively observing the patient in the home. And so this would say something like the ambient sensors show that he is sleeping in his recliner chair all night for the last 2 nights and give the date. And then before that, he slept 99% of the time in bed. And that was between the months of, let's just say, May and July. So this is an objective assessment that supports that maybe there's an exacerbation going on in the class 3 CHF patient. The assessment would come from the vital sign equipment that's in the home or from the smartwatch that they would be wearing, as well as some of the self-report from the voice memo. In this case, we can say that the patient on the voice memo has a new cough that showed up, and he reports he's not sleeping well and he's not taking his usual walks. And oh, by the way, the sensor data supports this, and that his behavior and data signals a probable congestive heart failure intervention. And then suggestions for the clinical team on what you might do next. And those suggestions, of course, could be different depending on whether this would be something that docs would be using, or nurses, or families and caregivers, or older adults who want to know an objective update on themselves. We haven't encountered a whole lot of older adults that are interested in that kind of information yet, but there are some, and I believe that there will be more in the future as people who have become very accustomed to looking at their data on their Garmins and their Apple Watches as they age. That's probably not going to change with time. So I think we're going to see more and more of that. So let's take one more pivot here and look at robots, because I think robots are a part of the smart health monitoring home of the future. I honestly don't see a future without robots in the home. Um, I think that's, down the pike a bit, but with the changes in large language models, we've also seen concurrently huge advances in robots, especially humanoid bipedal companion robots. And so what we're doing is we've actually been invited to observe the deployment of Abby the robot at Eschaton, which is a senior living corporation that has multiple properties across California. And they are implementing Abby the robot, which is a humanoid companion social robot out of Australia. And we will be observing this 12-month deployment of Abby the robot in a memory support neighborhood in one of their communities. And so this will give us a lot of insight into how does someone who has a dementia diagnosis or is in significant cognitive decline because they need to be a resident in a memory support neighborhood, how do they experience and receive a social robot that speaks 90 languages fluently and will originate conversation or initiate conversation with participants? So we're excited to add this to our research portfolio and see where robots take us in the future. So, what do we know about smart homes and robots in general? After I've done this research now since 2015, these are sort of the big ideas that I'm just pulling together. And it says the source here is Dr. Fritz's research because it's really the holistic view. What we know is that we can automate recognition of health events. We know that older adults can manage ambient sensing better than they can manage wearables in general. Some can manage wearables pretty good, but we've had a lot of instances where our older adult participants have actually said to us, if I have to keep wearing this watch and try to charge it, I want out of the study. And so we take the Apple Watch away and then we just leave the ambient sensors and they're just fine and happy and they stay for the full 12 months in the study. We also know that older adults are open to this kind of smart home monitoring. They're even open to robots to a degree. Even our 80s and 90-year-olds right now are open to this. But we also know that the healthcare team doesn't know what to do with this data. And so there's a lot of work that needs to be done around that. I think these direct comments from participants from previous studies really show how, in general, I think they're representative of how many older adults feel about robots in particular. No robots feeding, bathing me, or putting me to bed, but they would be okay for almost anything else. And they also want the technology, whether it's the smart home or the watches or any other technology device that you deploy to their home, they want it to be specific. They don't want some kind of general monitoring, and they don't want a system that's going to make them dependent on it. They really value their autonomy and their right to self-determination. So, based on all of the reading in the smart space and the last decade of research, I think that the future smart home involves these things, which include smartwatches or any kind of worn device. I believe that it's going to include robots. It's probably going to include chatbots and some kind of sensor-based monitoring. And this information will go to both the clinical team and the family or community that supports the older adult. So, in order to actually live out our health equity ideals, I also started the Global Gerontechnology Center for Nursing Science here in the School of Nursing. And this is actually funded in part by Global Affairs at UC Davis and the Healthy Aging in a Digital World Initiative. And this is growing fast enough that I'm actually in the process of trying to hire help to help me manage all of the nurses, nurse scientists, and those who work with them, including engineers and computer scientists in other countries who want to work with health technology, who want to do research, who want to try these things with the older adults in their countries, in their languages, with their culture. And this is really about using the resources and the talent in resourced countries to support health equity in countries who still don't have a lot of resources. And so on this team, we have people from Japan who work with robots and sensors and technology care models. We have folks from Australia, the United States, the Netherlands, and we have Dr. Atakaro, who is from Ghana. And he is the one who helps us understand what it might be like to deploy technologies to, for example, older adults in Ghana, which is a country that doesn't have a lot of organized resources around healthcare, but who he reports the older adults in his communities all have smart homes and smartphones, and they all say that they would love to receive healthcare on those devices. And so we started the center, held the first workshop last spring. Dr. Mohammadi, who is here at the top, is the only person not trained as a nurse that's on the founding group of delegates. And she is actually a computer scientist and architect in the Netherlands, working on empathic smart environments. We can talk about that another day, but her work is super cool. We've published in the American Academy of Nursing's journal, Nursing Outlook, and are connected with these countries already. So what are our policy considerations around this? Here's a list of things that really impact older adults' ability to age in place. And you can imagine that policies around housing and the supply and whether or not ADUs are available in certain areas to be put on properties that already have existing homes. The lack of age-friendly home design impacts older adults' ability to age in place. Healthcare and long-term care services also impact this. People want to remain at home as long as possible, but if you start requiring more and more human care, the government and the taxpayers are not going to pay for that. So you end up having to move to the next level of care where you are cared for along with many other older adults. So looking at policies around this and how technology could be leveraged to re-envision this is really needed. Looking at transportation and technologies that are becoming available, like self-driving cars, but also in rural America and the lack of access, and even in urban areas where planning remains car-centric, is really important for us to think about. And if that's not going to change, can we change how we deliver care? And can we do that in the home so that transportation is a non-issue? And then there's broader ideas and technology around, for example, Meals on Wheels, and how might we use something like that to leverage technology to help older adults remain in place. And of course, cuts to all of these programs negatively impact that. And emphasizing age-friendly communities both federally and at the state level, I think will be really huge. And luckily, we're seeing some of this in some of the strategic planning documents that are coming out, both at the federal level and at the state level. But what this tells us really is that we need lots of people doing lots of research in lots of ways to find immediate, innovative solutions to support older adults' ability to age in place. So with that, I thank you for listening to the presentation, and I'm happy to have a discussion, talk about questions, and leave you with this prompting question. What can we do together in medicine, in nursing, in health policy to create these immediate and innovative solutions for older adults?
So amazing. Thank you so
With
much.
that, I'll stop sharing so I can see everybody's lovely
Yeah,
faces.
yeah. We have a good group here today. So I'm going to pause and see if I didn't see anything in the chat, but would anyone like to raise their hand to ask a question both about the technology or the evaluation or any other components? Don't be shy. Um, I had a question to get us started. And then I'm coming back to all of you, so please be forming your questions. My question, Shelly, is really obviously I think of you as an implementation kind of first person. I love that you've centered this in real world experiences of older adults and then real worlds, like what do clinicians really want and need from the systems. As you think about that, I was curious when you say chatbots, in the example that you gave was really about summarizing all of the data for somebody else. And I like that, thinking about chatbots from a clinical or a caseworker standpoint, rather than an older adult is going to use a chatbot or wrap
Right.
around a chatbot around it. Can you talk more about how you fit the right technology platform to the right audience and you talked about wearables and then you talked about chatbots.
Yeah.
Is that like qualitative work or like how does that
Mhm.
emerge when you're thinking about a new technology and sort of where it fits into that spectrum?
Yeah, so probably a lot qualitative because I will tell you, actually, even though I'm in this space, I'm a qualitative methodologist. So I just surround myself with super smart people who can do math because I don't do that, and why not have the best team doing that? So we really work together, both nursing and engineering, to figure out this question of how do you deliver the right information at the right time to folks? And so who is your intended audience? That is a question that we figure out right at the beginning of designing something. So with the chatbot, for example, in my mind as a nurse, I was thinking, all of the data dashboards are great. Like when I look in the electronic health record, I see vital sign trends. I see white blood cell count trends. I see, I can look at those different things. But when I think about older adults at home And I think about having a huge caseload and how many nurses don't know what to do with this new form of evidence for evidence-based practice, right? Like, this is not in nursing curriculum. I'm trying to get it in nursing curriculum, but it is not in nursing curriculum. It's not in medical curriculum at this point. And so figuring out who your audience is and what they would want to know really guides that. From a clinical standpoint, what I've told the engineering team is like, docs and nurses are going to look at this information. If you're lucky for 1 minute, you've got 60 seconds to capture their attention and deliver something that's meaningful to them before they walk in the patient's room, right? And so that was part of the idea of the chatbot. Now, this is envisioned for home health nursing, to be able to hop on and say, give me an update on my patient before I make the phone call to them or before I go on the home visit. And that's really envisioned as taking all of that evidence that we don't know what to do with and having it be delivered to us and curated in a way that we know what to do with it. As a nurse, I know how to read what the radiologist's interpretation is of the chest x-ray, right? And this is kind of like that.
I love that. And then I love that it sounds my second question was about team communication. It sounds like you're able to communicate with the engineers, and I mean this in the with the greatest of respect, that a brand new device or brand new data, like the practicality of what that means, right? I think
Mhm.
I'm constantly being like, that's amazing. We can get a lot of information for it. But yeah, it's like we have one data point that we want to communicate or two data points, right? So we don't want to lose all of that level of granularity, but we also have to really boil it down to what people want and this idea that LLMs might be able to do some of that summarization that has really plagued us for a long
Yes.
time.
Yeah.
Okay. I have two questions in the chat. The first is about smartwatches.
Mhm.
As smartwatches add even more types of health sensors, how can this be integrated into dashboards and used to inform families and healthcare teams about newly discovered health issues? Did you have anything
Yeah.
more to add to that one?
Yeah. So, I mean, they can absolutely be today integrated, but they won't be because, um, frankly, healthcare in the United States is a capitalistic business entity. And the folks who make the smartwatches um, would love to give information to the folks who run the EHRs, but there seems to constantly, in my experience, be a business disconnect that leaves the patients, unfortunately, at a loss for how to integrate their information. I would have thought that we would have done better with this as a society by now. I remember being in the emergency room when the first Apple Watch with the cardiac rhythm on it, the first patient who came in and said, my watch says I just went into AFib, right? And the ER doc and I looked at each other and I'm like, you're the doc. What are you going to do with that information? You know? So, but for all the docs who are on here, I know that you've probably experienced that, right? And part of this is even if devices are FDA approved, which all of these devices are supposed to be that are on the market in the United States, it doesn't mean that they have the specificity that we require in healthcare. And so until those two domains meet, I think that this is going to be difficult, and we're still going to end up with patients reporting their own information. Hopefully, we're becoming more open as healthcare workers to listening and receiving that information from patients and not just discounting it. Because I will say some of this information is pretty darn good.
Yeah, that's why, I mean, it ties back to what I was already saying. So it's a great answer about the implementation focus. It's like, not only do we need to figure out a way to integrate it and to know what to do on it, but there is a culture change within medicine to use at-home data and like the
Mhm.
right type of at-home data. Is it the level of, yeah, like you're saying, the level of granularity. Um, we're doing a lot of home blood pressure stuff, and that comes up a lot. It's like there's a lot of evidence that home blood pressure is the gold standard for blood pressure, right? We only see people for a very brief time to check their blood pressure. If you have a lot of blood pressures from people out in their daily life, it's closer to their real blood pressure.
Mhm.
We've known that for a long time, but when you
Mhm.
interview doctors, they'll say, "Oh, I want them to come in." to get their blood pressure checked. They're worried about it. They're worried about the person taking it right, or it's a very interesting
Mhm.
non-technological
Mhm.
solution of just getting the data point into the EHR for them to see it. There's a whole other part around that that has a workflow and the follow-up,
Absolutely.
that you need to work
And the
on.
trust in the data, because you're making a clinical decision based off of it, and you're
Exactly.
you're responsible for that. You're
Exactly.
liable for that, right?
Exactly.
Um, but I think this is where I think the smart home, if, eventually would be able to provide the kind of information that is the gold standard, which is if people are taking their blood pressure at home on a daily basis or every other day. I mean, we're exploring even how do we curate that information for each of these audiences, which is the patient themselves, their family or caregiver, or the clinical team. I mean, you can use large language models to give you summaries week by week of, or ranges of blood pressures, systolic, diastolic, whatever it is that you want. You could literally tell the chatbot to return to you the information, and it will pull everything that's been in the continuous ambient monitoring space at home. We forever in healthcare, we've made clinical decisions based on single slices of data and time, right? Which is the patient comes into the doctor's office, and this is their blood pressure, this is their blood sugar. We're a little better with blood sugar now, but we make clinical decisions and prescribe medications and doses based on that. And this allows us actually better evidence, because where all of life and health and illness happens is really in the home.
Yep. I love that. Um, and you guys can raise. Oh yeah, I see a hand raise, and then I have one more question to end in the chat. Go for it, Matt.
Hi, I'm Matt from the Office of Population Health at the Cancer Center. We're also at Aggie Square as well.
Mm.
Yeah. So you mentioned about the security. I actually really interested about the LLM chatbot applications that you mentioned, and then I was wondering, like, could you speak a little bit more about the how you guys handle the security or address the PHI protection things? Well, we also have this kind of AI projects, um, but we have been paused on those because we are waiting for this internal guidelines and the AI guideline from the state, which they're still not giving us. I mean, but they mentioned that we have to be careful how we using
Yeah,
any tools related to the AI. And so
yeah.
that's why we cannot move forward with those projects. And then, so I just want to know like how you guys building all these chatbots. I mean, one of the solutions I know that they're kind of building all these things this LMM model like in-house rather than
Mhm.
like in some security um data server, which making it possible. But I guess I still need to go through a lot of like regulations and others. Yeah.
Yeah, so I mean, we've had this very discussion on our team, and we came to the conclusion that there is no way that we can build models that perform as well as what are out there with GPT and Claude and Gemini and some of the others. But all of these, or most of these, offer privacy enabling versions, which means you can pull them offline. They're not using the data to train themselves. So you're not, I mean, you're getting whatever the model is when you pulled it off and you paid for the privacy enabling version, which means it's not training on your data. We're also not giving it any identifiable data, right? So it's completely de-identified, which means it's not technically PHI, right? So we have participant codes, like I gave you the example of UCD 123, right? So that might be a code that is assigned to an actual participant in our research study, but that's actually converted even to a different code before we give any kind of information from this participant to our already offline privacy enabled chatbot or LLM, right? And so this is sort of how we're working with the security version of it. And of course, these are hosted on the engineers that I work with are still at Washington State University for this particular project. And of course, it's hosted on a university secure site. Um, for my part, the information that I collect on participants, that is health information, is stored on OneDrive here, which is our HIPAA compliant OneDrive. And those processes are followed and IT certified for this particular research study here at UC Davis, right? So I hope that's what you were looking for in an answer. And I'm happy to chat with you offline and connect you with our engineer who could tell you more about the technical details of what she's doing on this front.
Yeah, I mean, I would love to learn more about that as well too. But yeah, but thanks, thanks for
Yeah,
answering my
that was a
questions
great
here.
answer. Yeah.
Yeah,
And then in our last 4 minutes, perfect. I was going to end up with this final question in the chat. It's sort of it's a softball, but also nice. Like, what about your funding needs, or where are you looking for funding? You are crossing a lot of domains. Can you talk through how you fund your work and what you think the future of funding for this kind of work would be?
Yeah, I mean, I think it's right in line with where the government's headed. And so most of my funding has come from NIH and through the engineer that I work with, NSF. NSF is much more computer science technical oriented, but they have some crossover into health. And so, but the majority of my funding has come from NINR. And then a recently submitted RO1 is to NIA because it's for a lot more money than NINR has. And nurses are always the lowest funded on the table. So now we're big enough. We've got to go to NIA. So that's part of it. And then the Betty Irene Moore Leadership for Nurse and Fellowship for Nurse Leaders and Innovators has funded a good portion of this work as well. Private foundations, we've applied to private foundations for some of this work, and frankly, a bunch of what I do is unfunded. I'm just passionate about it, so it gets done at midnight.
I love your passion. It's such an important area. It's like multidisciplinary work. Just really lucky to have you with us here today to share about it. I know everyone can email you because I know you as the kind of person that would welcome emails or follow-ups
Yeah,
if people want to learn more. But I really appreciate it. And this was a really great session. Thank you all for joining us today. Have a great afternoon, Shelly. Thank you again.
thank you. Bye-bye.
Bye,
thank
everyone.
you. Bye.